I'm speaking to you from the red zone of the COVID-19 from Mumbai, South Mumbai, which has got the largest number of cases. In our own ward also is the largest number of cases. So I hope you all are taking care of yourselves and I hope your families are safe. So today I'm going to talk about depression and diabetes, the two deadly Ds. Of course, the season is for the deadly C, but let's today talk about depression and diabetes. So what I'll try to cover in my talk today is that why diagnosing depression in diabetes is important. Is there a causal link between the two? What are the challenges in diagnosing and treating depression and diabetes? These are a few things that I'm going to try to cover up in the next 20-25 minutes, and then we could discuss further. So what is diabetes? I am not going to go into what is diabetes. All of you all know, and you all know better than me what diabetes is. I'm going to come to defining what depression is. So we psychiatrists are not as lucky as you physicians. You all can just draw some blood, uh, do a check and diagnose whether the person is having diabetes or not, and various other ailments, or put a BP apparatus, or put a stethoscope, and come to know what the findings are and what the diagnosis is. So we are the unlucky ones. We do not have any biological markers as yet of depression, or for that matter, for most of the mental illnesses, we still do not have biological markers. Unfortunately, still we depend upon the symptoms, and based on the symptoms, we have diagnostic criteria, and according to that, we diagnose most of the mental illnesses, including depression. So I'll just very quickly go through what are the symptoms of depression, two cardinal signs of depression according to the DSM-5 criteria, which is most widely used world over. Is one is depressed mood. The mood can be depressed, either sad, anxious, or irritable. Irritability is also one of the most important features in depression. Most of the times we equate depression with sadness of mood, but irritability is also a very, very common emotion experienced and seen in depression. The second is anhedonia. Anhedonia is loss of pleasurable activities in most of the things. Previously, what was pleasurable to people, they lose interest and pleasure in any of those activities. I will not go into details of each symptoms. uh, Appetite and weight changes, it could be decreased or increased appetite or increased weight. Same thing is with sleep, increased sleep or decreased sleep, insomnia or hypersomnia. Fatigue and lack of energy is also one of the symptoms which is most very commonly seen in depression. Psychomotor changes, that is either agitation, severe restlessness, or retardation, where people become very, very slow in any of their activities. They are lethargic and slow. Feelings of worthlessness and guilt are also commonly seen. Then there are cognitive symptoms in depression, which are very common, and sometimes, most of the times, we miss. That is impaired concentration, memory difficulties, difficulties in making decisions. These are very commonly reported by patients, which we miss most of the time. Then the last and the most serious symptom of thoughts of death or suicide. So the criteria says 5 out of these 9 symptoms, if they are present for 2 weeks or more, you can diagnose a person as suffering from depression. So 5 out of these 9 for 2 weeks or more would be a diagnosis of depression. That would be uh, there. Just a minute. I'm sorry. I'm sorry. Yeah. Sorry for that. So all the work is going on teleconsultations. That is why this is the scenario these days. The mobile doesn't stop ringing. Okay. So it is said that there are around 189 million individuals who have diabetes. I'm not sure about the figures. Dr. Faraz would have the latest figures about the number of people suffering from diabetes, but there is certainly a link between diabetes and depression. It is said that individuals with diabetes have a higher prevalence of depression and vice versa also. So in the general population, if we see, depression may affect around 3 to 5% of the population at any given time, but the rates in diabetes, it goes up to 15 to 20% of diabetics may suffer from depression. So the rates become almost 4 to 5 times more than what we see in the general population. And that is why it is very, very important to diagnose depression in diabetes. So most of the times it is unrecognized in patients with diabetes, and the coexistence of them both together may worsen each other. जैसा बोलते हैं ना, वो दोनों का कुंडली मैच नहीं होता है. So they don't coexist well with each other, and most of the time they worsen each other. Again, another study, and I have intentionally tried not to take any Chinese studies because we are all very, very angry with China these days and cursing them day in and day out. So more studies which show that the prevalence of clinically relevant depressive symptoms in 31% of patients with major depression. Uh, Vice versa also, it is seen that people with depressive disorders have got a 65% increase chance of developing diabetes. So it's the other way around also. And the prognosis, as we spoke earlier, of the two diseases, if they occur together, is worse. That is, in terms of complications, treatment resistance, mortality, it is worse when both the two diseases are combined with each other. So here we see that people with both depression and diabetes have a worse self-reported health than any other illnesses. So if we see only asthma, if we see arthritis, if we see only depression or depression with arthritis, here I don't know if you all can see my pointer. Depression with diabetes, they report a worse self-reported health overall. So it's worse among all the illnesses that they have compared with. Also, their physical and mental health status when depression and diabetes co-occur is worse, and this is shown consistently in all the studies. So the gray bar is for people only suffering from depression, and the black bar is for depression and diabetes. So here we see that in all the studies consistently it has been shown that people who have been suffering from diabetes and depression do worse, not only in physical health, but in mental health also. They are the ones who will keep revisiting your OPDs. They are the ones who will utilize healthcare more than any other patient. So if we see here, this is the blue one is of patients. This bar is for patients only with depression and with depression and diabetes, and the red one is without depression, that is only diabetes. And we see when the two illnesses occur together, the ambulatory visits, emergency department visits, the hospital inpatient days increases. We decide that this patient is doing well and we want to discharge this patient, and the next day we go for rounds all ready to discharge this patient. The patient will come up with a new symptom altogether and will prolong the stay in the hospital. So patients who have depression and diabetes, their stay in inpatients also increases. So they are the ones who use the healthcare facilities more than patients who have been suffering only from diabetes. Mortality is also significantly high. If you see on the left side, it is the diabetic and the depressed population, and this is the non-diabetic population on the right side, and you can see that the mortality rates are high. Even the severity of depression, if you see the above graph, where this scale, CES-D scale, when the score is between, this is a depressive, this is a scale to measure the severity of depression. This is a Center for Epidemiological Studies depression scale. When the scores are less, that is between 0 to 15, the mortality rate is less. When the scores are more, so it is when it is more than 16, the mortality rates are higher. So we see that it's not just the coexistence of the diseases, it's also the severity of depression determines the mortality rate of these patients also. And similarly, when we see in non-diabetic patients and with only with depression, the mortality rates are lesser when they are compared. So to summarize, till now, we know that depression is common in diabetes. Depression is associated with worse outcomes, increased mortality, and depression is yet under-detected and highly treatable in any population. So synergistically, if both the illnesses occur together, both the diseases occur together, it is also seen that there is higher incidence of micro and macro angiopathic diabetic, late diabetic complications. So there are multiple studies. The first one on this slide is a prospective study where they have found that people who had depression and then developed diabetes, the chances of developing coronary artery disease was higher. Similarly, in children also, it has been seen in type 1 diabetes to the developing retinopathy more when they have had emotional disturbances. Similarly, for erectile dysfunction and diabetic foot, so patients who have got higher rates of depression, diabetic patients, they have a higher rate of erectile dysfunction and diabetic foot. So we see here that, even the micro and the macro angiopathic complications, which generally develop late in the diabetes, the rates are higher if depression coexists with them. So again, we see here that higher heart diseases, body mass index higher, worse self-care is reported, and worse adherence to diet and exercises advice are, the adherence to these advices are worse. There's an increased mortality. So is there a link between depression and diabetes? Let's explore this. So I have divided into two segments the link that could be there for depression and diabetes. One is a behavioral link. Just imagine a patient who has depression, and obviously in depression a person doesn't feel like doing anything, doesn't feel like going out of the house, doesn't feel like moving much, is lost interest, self-care is poor, and definitely because of this behavioral link, they develop a higher chance of developing diabetes. So they have reduced physical activity, they have poor diabetes self-care. That is, a depressed patient, when you tell this patient that you need to take care, we every day struggle with this, take care of your diet, do exercise. But if the patient is depressed, he's not going to do all these things. He will not feel like doing all these things. He might feel ridiculous. Hey, doctor, kya bol raha hai? I don't feel like getting out of the bed. I don't feel like doing any activities. What I will do, exercise and dietary control. So there is a behavioral link to this, that depression may lead to diabetes, and it's a vicious cycle actually. If we see, patients who have got anxiety and depression will have poor self-care, poor dietary control, poor physical activities, they will put on weight, they will develop diabetes. Because they've developed diabetes, they'll feel even more lethargic, and it's a vicious cycle that they usually get trapped into. So this is very easily understandable that there is a behavioral link. But very interestingly, there is also a biological link to this. Depression is a phenotype for a range of stress-related disorders which lead to an activation of hypothalamic pituitary adrenal axis. And we all know when this axis is activated, there is increased secretion of cortisol and prolonged secretion of cortisol. We all know what are the effects of that. So depression activates this hypothalamic pituitary adrenal axis and causes release of cortisol. There is also dysregulation of the autonomic nervous system. And very interestingly, now people are looking at depression from a very, very different perspective altogether. There are enough studies which are looking at depression as an inflammatory disease. Similarly, diabetes and obesity also are being looked as inflammatory diseases, and there could be a link between the two. Both could be inflammatory diseases. So biologically, both these diseases could be linked together. That is why the coexistence is higher. Also, there is metabolic programming at genetic level, where they are saying that undernutrition in utero, that means when during the pregnancy period, may predispose people both to depression and diabetes. There is enough evidence now to say that people who have undernutrition during their pregnancies, those children have a higher risk of developing uh, depression and for diabetes. So this is for the biological link that could be there between depression and diabetes. So it's a bidirectional association. Depression can lead to diabetes, diabetes can lead to, to depression. So it is vice versa. And of course, when both coexist, there is a problem. So so I'm going to comment what are the challenges when both these disorders coexist. So sometimes it can be a little tricky diagnosing depression in diabetic patients, because there could be a lot of symptom overlap. In diabetes also, there is fatigue, there is lethargy that the patient may complain of. Similarly, in depression, they will complain of fatigue and lethargy, and sometimes we may attribute it to diabetes and may not look at the depressive angle altogether. So we need to be aware of the symptom criteria for depression, and that will give us hints, to diagnose depression. When we ask about the mood of the patient, that तुमको मन में कैसा लगता है, do you feel sad, do you feel depressed, do you get negative thoughts? So these things will maybe able to give us an indication whether the patient is suffering from depression. Just the physical symptoms may confuse us, that whether these physical symptoms are due to diabetes or due to depression, and you may attribute it to diabetes and neglect the depressive component. So look at scratch the surface a little bit and ask for depressive symptoms. Ask them कि ज्यादातर आपको मन में कैसा लगता है, क्या आपको ज्यादातर मन में उदासी, मायूसी महसूस होती है, आप जिसमें जो चीज में इंटरेस्ट रखते थे वो आपको इंटरेस्टिंग लगता है कि नहीं लगता है, पहले जो आप सोशलाइज करते थे वो आपको सोशलाइज करने का मन करता है कि नहीं. जस्ट स्क्रैच द सरफेस अ लिटिल बिट and you may be able to diagnose depression with greater accuracy. Secondly, depression is also associated with a lot of somatization. Lot of our depressive patients come with somatic complaints. इधर दुखता है, उधर दुखता है, ऊपर की सांस ऊपर रहती है, नीचे की सांस नीचे रहती है, पेट का पेट में गैस फिरता रहता है. All kinds of weird symptoms they come up with, and sometimes they may have amplification of physical symptoms also. So that is why diagnosing depression is very, very important. Sometimes the symptoms are also amplified. A little bit of paresthesia might be reported as very, very severe burning sensation. Sometimes depressed patients also complain. When depressed patients have symptoms of anxiety, that time they also complain of these physical symptoms of burning sensation, tingling sensation, which may not be related to diabetes. You may have controlled the sugar very well, but because of the anxiety which may be associated with depression, the patient might be complaining of these things. That is why, again, I go back to the criteria. That is why you need to scratch the surface, look at all the symptoms of depression, see if they are having those symptoms of depression, and that may guide you to treat the patient properly and not just blindly give pregabalin, gabapentin, and these things which may not be indicated at that time. Of course, it works in anxiety also, but then your diagnosis will become more confident if you refer to the diagnostic criteria. When depression occurs, there's difficulty in diabetes management also. They will not follow your advice, they will not take the medications properly, and then they may come back and saying that I'm not feeling better, and they may make you also feel worse. when we have not detected that this patient is suffering from depression, they'll come and tell you, oh, you've been giving me so many medications and I'm not improving. So because they're not following the advice that is given to patients. Sometimes people with depression regulate their emotions with foods and substances. So comfort eating, when people are emotionally disturbed, they start eating more. Today, there is a big controversy whether Kim Jong-un of North Korea is alive or dead. I was just today morning reading an article that he has a major problem. He's got a lot of stress and he keeps eating and regulates his emotions with food. So a lot of people that we see, they are, when they are depressed, they eat a lot or use a lot of substance like smoking, alcohol, and these things. So we need to diagnose depression. If we manage that properly, maybe these things might come under control. Also, changes in health seeking patterns and behavior. They'll not follow through your appointments, they'll not come when you call them, they'll not do the blood sugar, they'll not do the tests that you have advised them because of their depressive symptoms. So rather than just getting irritated on them and angry on them, see why they are not doing this. Why are they so callous about their own health? Maybe depression is one of the reasons. I'm not saying it may be the only reason, but it could be one of the reasons. And if it is there, you need to detect and treat it. So I've already gone through what are the signs of depression, and let's go on to the evaluation. One thing that is very, very important that I would like to highlight and that we see very, very common. I think the remaining meeting time is showing is only 9 minutes, so I'll just rush through. So sometimes what we usually see that, what physicians do, what doctors generally do, even when they have diagnosed depression and they know that this person is depression, quietly sneak a SSRI, लिख दो, Nexito, Certa, कोई भी brand SSRI का. But they don't talk to the patient, that explain to them that there is a mind-body connection, you are suffering from emotional symptoms and you need to work on that, how you need to come out of that. Spend some time with them. Just writing a prescription of an SSRI will not work. Sometimes physicians refer the patient back to us, कि अरे इसको ठीक नहीं हो रहा है यार, ये depressed है. We write the same medication, but just talk to the patient. So they tell us, अरे तेरे से कैसे ठीक हो गया, तू तो same medicine दिया. Just talking to them, making them understand their mind-body connection sometimes helps, that your symptoms all are not from the body, some of them are from your mind also, and you need to work on that. Very easy to use PHQ-9. It is an easy to use questionnaire. It is available on your on the web. You can download it, give it to your patients. It's available in 11 languages. Pfizer has translated it. If you have Pfizer MRs coming to you, ask from them. Patient can fill it up. It will reduce your time to diagnose depression. Management just does not mean giving medications, but cognitive behavior therapy, lifestyle changes, which is also useful in diabetes, will go a long way in treating patients. Okay, I'll just come to the medications fast, and then 5 minutes we'll have for discussions. The choice of medication, okay, the antidepressant should not influence body weight, no interaction should be there, should not be hepatotoxic, should not produce cardiovascular blood pressure changes, minimal sedation, minimal sexual side effects. Is it all this possible? Not at all. Okay, I wish all this was possible, and I'm trying to make one medication which would have none of these. Once that is made, you will read that I won the Nobel Prize. So all medications will have their own side effects. We need to choose the best which is for the patient, depending upon the side effects that the patients have. The first line medications, of course, are SSRIs and SNRIs. SSRIs that are available are fluoxetine, sertraline, escitalopram, fluoxamine. So these are the SSRIs that are available. SNRIs, fewer are available. Desvenlafaxine, venlafaxine, duloxetine. These are the commonly available SNRIs that are there. We need to be mindful about drug interactions. Some of the SSRIs like fluoxetine interact with lot of drugs, so we should avoid it. Use drugs like venlafaxine, duloxetine, when people have got neuropathic pain, it is useful in both the conditions. If patients have got sexual side effects, avoid SSRIs. Then bupropion is a good medication to treat them. Avoid medications which will increase appetite and weight gain, like mirtazapine, olanzapine. Those kinds of medications one should avoid, which will increase their appetite and cause weight gain and poor diabetic control. So, okay, diabetic clinics have got sugar management, nutrition counseling, exercise, foot care centers, eye care clinics, but all this is useless without mind care. Unless the person is in the right state of mind, he will not follow all these things. All your efforts towards making the patient better might fail. I will end here since we have only 5-6 minutes remaining. If there are any questions, I would be glad to answer.
Thank you so much, Dr. Malik Merchant, for that lucid presentation. It was really nice to know, yes, there is definitely a connection between diabetes and depression. Now the forum is open for discussion. Any one of you want to ask, please unmute your mic and you can go ahead with the questions.
Hello, good evening. This is Dr. Amir here.
Good evening.
Yeah, I have seen a few elderly diabetic patients on escitalopram. So even after continuing for 6 months, their symptoms not resolving. So what is the next line of antidepressants we go for in such patients?
Okay, it's a very, very interesting question. So there was a very large study, a naturalistic study done around quite some time back. So this exactly says that sometimes the patient may not respond to the first line medications. If you've given an adequate trial at a good dose for around 4 to 6 weeks, that's the adequate trial. The maximum therapeutic dose is 20 milligrams. If you have done that and still the patient is not responding, then you can shift the patient to an SNRI, maybe desvenlafaxine, maybe duloxetine. Rather than trying another SSRI from the same group, of course you can try, it may work, but the logic is that why to try a medication from a similar group, that is an SSRI? It's better to shift and try the patient on an SNRI, maybe desvenlafaxine or duloxetine, and see how the patient is doing. Also, sometimes combining cognitive behavior therapy helps along with these medications.
Yeah, thank you, doctor. One more doubt. Mostly for
Yeah.
diabetic patients with neuropathic pain, we usually
Yes.
prescribe gabapentin and nortriptyline combinations. So in
Yes.
such patients, if they have depression, if we prescribe escitalopram, will there be like interactions?
Not actually. See, what happens is that gabapentin and nortriptyline combinations, if you see the nortriptyline component in that, those combinations is very less. It will not have an antidepressant effect. A 10 milligram and a 25 milligram nortriptyline is not an antidepressant dose. And you can easily add an SSRI because the mechanism of action of nortriptyline, it works mostly on the noradrenergic receptors, and this is an SSRI that you are adding. So yes, definitely you can combine both. What becomes risky is that when you're giving gabapentin and then to use benzodiazepines along with that, that might cause a little bit of a confusional state, increase sedation in patients. So benzodiazepines, one needs to be cautious when one is using gabapentin, but SSRIs like escitalopram is okay to use.
Right. Thank you, doctor. And one more thing, which is the like most important neurotransmitter? Like for the past half a century, it's been proposed serotonin. Now we are getting the research dopamine and noradrenaline also have a significant role to play in depression. So what will be the approach from now on?
So yes, the monoamine neurotransmitters were looked at for the last whole century. And now what they are saying is that they are not the only receptors that are playing a role in depression. They are looking at the glutamate receptors also. If you must have read about certain studies of ketamine having a very significant and rapid antidepressant effect, works on the NMDA receptor. So they're looking also at NMDA receptors and whether that will play a role in bringing about antidepressant effect. So you're very right. The serotonin receptor story was going on for a very long period of time, but they say that all the depression will not be just because of the serotonergic activity. In fact, inflammation is being looked at very closely as a causative factor for depression, and anti-inflammatory agents, although not anyone has not been developed to an extent where it can be used as an antidepressant, but they are looking at that also.
So I would like to interpret, or I would like to just end the session here because we have just less than a minute. So thank you all, and thank you, Dr. Malik Machin, for this wonderful session, and thank you, Dr. Ahmed, for making it very lively. So thank you all, and then see you all tomorrow at 4 o'clock. Thank you.
Bye. Thanks.
Thank you, sir. Thank you, doctor.
Thank you, sir.
Bye.